I'm Dr. Victoria, and this is George.
Today, we are joined by a special guest, Sophia. Today, we are going to talk about neonatal abstinence syndrome. George's cousin is Sophia's mom, and Sophia's mom has been abusing opioids for a number of years. When she found out she was pregnant with Sophia, she decided to turn things around, and she got the help of a counselor, and instead of abusing opioids, she started attending a methadone clinic and has had consistent prenatal care. But because Sophia's mom is currently on methadone as prescribed by her physician, and her history of substance abuse, we have to watch baby Sophia in the hospital a little longer than we would for most other newborns. George cares a great deal for his cousin and wanted to know what the care would look like for little baby Sophia. Neonatal abstinence syndrome occurs when the mother of a baby has a substance use disorder. This could be something like opioids, nicotine, benzodiazepines, PCP, marijuana, tricyclic antidepressants, or selective serotonin reuptake inhibitors. How much the neonate is affected depends on various factors, including genetic. Genetic variations in the mu-opioid receptors and catechol-O-methyltransferase genes influence susceptibility to a baby to opioids, affecting the length of stay and the need for pharmacotherapy. Also contributing to whether or not a neonate will be affected includes the number and what kinds of substances mom has been using, the frequency of use, how many different substances at one time, and the amount. Also important are the maternal nutritional status, amount of stress, comorbid psychiatric conditions, and the placenta's ability to metabolize opioids. Depending on what has been used, the timing of symptoms will vary. Short-acting heroin has a short half-life and will usually present with symptoms within 24 hours since delivery. Longer-acting methadone or buprenorphine will give symptoms between 24 to 72 hours. However, this can be delayed for 5 days or later. Therefore, it will be important to monitor neonates at risk for neonatal abstinence syndrome for a minimum of 4 to 5 days in the hospital setting. When we suspect neonatal abstinence syndrome, there are some things we look for clinically. A change in the sleep-wake cycle. Patients will have short sleep cycles, will have difficulty maintaining an alert state, and will have fragmented sleep. There will be a change in tone or movement, such as hypertonicity, tremors, and jitteriness. Autonomic dysfunction includes sweating, sneezing, achoo! Mottling of the skin, fevers, nasal stuffiness, and frequent yawning. As well, birth weight is often less than the 10th percentile for gestational age due to intrauterine growth restriction. In premature neonates, they may have different clinical symptoms compared to their full-term counterparts. Because of their immature central nervous system, they may have decreased receptor sensitivity and development, and as such may have a decreased ability to express motor dysfunction, decreased total substance exposure because there's a shorter intrauterine period, and there is decreased fat for deposition of the substance being abused. To diagnose neonatal abstinence syndrome, of course, we are going to look at the clinical presentation of our patient, but some further examinations are warranted. Urine tests have low sensitivity and are only positive if there has been recent exposure. Testing the urine of the mother is quite common as well. Hair may be difficult to obtain, and depending on certain cultures, this may not be an acceptable course of action at all. It is possible to test meconium. However, this is not common since lots of hospitals don't have this test readily available. In the umbilical cord, class-specific immunoassays identify drugs used, and this is sometimes done. Meconium and umbilical cord samples reflect second and third trimester exposure to substances of abuse and do not show if the mother has been abstinent closer to the time of delivery. There are many differential diagnoses to consider when a neonate presents clinically with signs and symptoms of neonatal abstinence syndrome. Seizures can be due to other reasons besides drug exposure. They can be caused by decreased calcium. This is common in preemies, intrauterine growth restriction, birth asphyxia, maternal diabetes, hypoglycemia in the baby, polycythemia, and hypoxic ischemic encephalopathy. Seizures from other causes, irritability, and hyperreflexia can all mimic neonatal abstinence syndrome. Fever or irritability could alternatively be due to sepsis, especially if the mother is an injection drug user, and it is important to do blood cultures and start empiric antibiotics. You may consider this if the mother of the neonate had fever, premature rupture of membranes, or chorioamnionitis. If the neonate was hyperthyroid, you may also get some similar symptoms. Usually the mother has hyperthyroidism in these instances. You may see mottled skin, and risk factors include polycythemia, so it is important to measure hematocrit. Warning signs include large for gestational age, maternal diabetes, and delayed cord compression. There are several labs that we will want to do when suspecting neonatal abstinence syndrome. These include a CBC, serum glucose and calcium, TSH, and we may or may not want to do a sepsis workup via blood cultures and empirical antibiotic treatment. We also want to check for comorbid conditions, including sexually transmitted infections that the baby may have gotten through vertical transmission, such as chlamydia, gonorrhea, hepatitis C, and HIV. Once we have identified that indeed we have a neonate that has been exposed to substances of abuse by the mother, it is important that we monitor these patients. Factors we look at include the presence or absence of tremors, expected reflexes, yawning, sneezing, excessive irritability, and adequate feeding, among many more. Different facilities have different scoring systems, and each system has its own pros and cons. A common one is the Finnegan scoring system. However, this particular scoring system is not good for preterm babies or babies more than 30 days old. Factors looked at in these scoring systems include excessive crying or yawning, presence of tremors, seizures, sweating, nasal stuffiness, or tachypnea. Now that we have been able to identify at-risk neonates and we know how to monitor them, the next thing we need to know is how can we best care for these patients? An important part of our care are non-pharmacological treatments. A goal is stabilization of symptoms. If a neonate has hyperactivity, which is causing excess rubbing of the skin and excoriations, we can tightly swaddle these infants. If the patient has increased irritability, some vertical rocking may be helpful. We want to control sensory triggers, loud noises, eye contact, or perhaps there is an oral hypersensitivity that could be alleviated by a pacifier. By paying close attention, we will be able to identify these triggers in our patients. Often, having mom room in can be very helpful, not only to be on the lookout for these things that her child may be sensitive to, but also to promote bonding between her and her child. An important topic to address is that of breastfeeding. Breastfeeding is safe if and only if mom meets particular criteria. This includes that mom can be sober and has a treatment plan postpartum, using the prepartum period as the test for sobriety. Mom had abstinence 90 days before delivery. If mom's urine toxicology screen does not show any non-prescribed pharmaceuticals, mom had consistent prenatal care, there is no other medical contraindication like if mom had HIV. If mom had HSV, she could just pump and dump if the nipples were cracked and bleeding, so she could still breastfeed in that instance. And if mom can commit to not taking any contraindicated substances during the lactation period. As well, if mom has been getting treatment for her prior substance abuse and is currently on stable methadone or buprenorphine, mom should continue to breastfeed. Low amounts of these substances are secreted in breast milk and can in fact help alleviate withdrawal. However, should mom abruptly stop breastfeeding, the child can go into withdrawals at that time. Mom should not breastfeed if there is any behavior or indicators of active abuse. If she has a positive urine toxicology screen, any relapse into substance abuse, including marijuana, has not had consistent prenatal care, and does not want to engage in treatment or give consent for us to be in contact with her counselor and treatment team. Pharmacologic treatment is for high-scoring neonates on their neonatal abstinence syndrome scoring system. In these instances, we give opioids. Several are available, but really, we just use morphine or methadone. This will be facility-specific on what is used. To know how much morphine or methadone should be administered, we use a symptom severity controlled dosing. This is often better than weight-based dosing, and we use our neonatal abstinence scoring guide to direct our treatment dose. If the patient had severe neonatal abstinence syndrome, we may need to bring in a second-line agent in addition to the opioid treatment. This includes clonidine and phenobarbital. Prior to discontinuing pharmacological therapy, we need to see that the neonatal abstinence syndrome scores have improved and we start to wean the patient off the medication. If there is more than one drug on board, we start with the opioid and then move to the second-line agent. We only discharge the patient from the hospital once the patient has been totally weaned at least 24 hours. If the patient fails their weaning taper and we have to put them back on therapy, we must wait 48 hours after they have stopped all medication before they can be discharged. After patients have been discharged, it will be important that they follow up with a pediatrician or their favorite family physician. They should also have very early follow-up so that any poor feeding or insufficient weight gain, just like any other baby, can be addressed. As well, at that physician's office, they can look for any remaining neonatal abstinence symptoms, as well as do a thorough ophthalmologic evaluation looking for nystagmus, strabismus, and refractive errors. In addition, we want to do a neurological development assessment. Long-term outcomes are difficult to sort out because there are so many other factors at play. Prenatal things like intrauterine growth restriction, low birth weight, prematurity, exposure to tobacco smoke, and postnatally, any pharmacological therapy that we've administered for neonatal abstinence syndrome, continued maternal substance abuse, socioeconomic and education levels of the family, and exposure to violence all confound our ability to really identify the long-term effects. For Sophia, I know George is so pleased that his cousin has really been diligent with her treatment plans and has renewed vigor and zeal for life to care for her new daughter. George is looking forward to being the best babysitter she has when he goes to visit. Sophia has a big family who is excited to encourage her and see her flourish. These little babies are precious and valuable and deserve all the love that we can give them. Thank you for joining me today, my healthcare team. I hope you'll join us next time. Bye-bye.